Okay, so insomnia. All right. We are going to talk a little bit about insomnia. And like I said before, we will do it in a question-based format. Okay. So yes, good morning. Good morning, everyone. It's afternoon now, 12:04. So good afternoon. All right. So let's get started with some questions. Then I'll go over some of the guideline-based insomnia recommendations, talk a little bit about practice pearls which are relevant to QE1, NAC, OSCE, whatever exam you're doing, and we'll take it from there. All right, so let's start with some questions. For people who are new, what I would suggest is try answering in the chat box. Try typing in the chat box. I have muted everyone because if everyone speaks at the same time, it will be hard to understand, decipher, and so forth. So I have muted everyone. Please type in the chat box. Okay, great. Which of the following best describes the relationship between insomnia and psychiatric conditions? Psychiatric conditions always cause insomnia, wrong. Insomnia always leads to psychiatric conditions, wrong. There is a bidirectional comorbid relationship, true. Conditions are unrelated, not true, right? There is some relation between them. It's a bidirectional relationship. Good. So correct answer C. A lot of you guys answered it. You guys are pros. Perfect. Next, we have two questions, true or false. I have put some variety over here. So what I would like you guys to do, so good, you can write T and T, true and true, T and F, true and false, F and T, false and true, and so forth, whichever way. I see some confusion in people, right? Some are saying both are false, some are saying one is true, one is false, and so forth. Let's go over this. So, over-the-counter sleep aids and medications with drowsiness as a side effect are recommended as first line. So these medications include, what are some of the medications? Like over-the-counter medications and medications that cause drowsiness as a side effect. Can you guys type some of the options? Very good, Dr. Nix. Awesome. Antihistamines, right? You can take Benadryl, it'll make you feel sleepy, right? You can take Atarax, right? Hydroxyzine or whatever it is, that'll make you feel sleepy as well. Anything else that you can think of? Drowsiness as a side effect? Only one person answered. Okay, we have another one. Pseudoephedrine. It doesn't have drowsiness as a side effect. Ephedrine has wakefulness as a side effect, not drowsiness, right? Gravel, very good. So gravel also has an antihistamine, right? Absolutely. So it is also an antihistamine that is a side effect. Anything else you guys can think of which is drowsiness as a side effect? You take the medication and it makes you groggy, it makes you drowsy, all of that. Cetirizine less, okay, Dr. Amar, cetirizine is less. More older generation antihistaminics like Benadryl and stuff. So everybody, we already covered antihistaminics. Let's move from there, okay? We already covered antihistaminics and motion sickness antiemetics. So two things are done. Let's move from there. What else can we do? So we have antihistaminics we talked about. We talked about gravel and antiemetics. Anything else? Very good, very good, very good. Shanza's iPhone, very good. So melatonin, right? Melatonin. Over-the-counter sleep aid, that is melatonin, right? Now, what are, no, Zolpidem is not. Zolpidem actually is a medication that where drowsiness is not the side effect, it is a main effect, right? It is a main effect. So that's not correct. But melatonin don't cause a side effect. No, yes, very good, Dr. Nabila. So melatonin has no side effect as drowsiness. It is its main effect. But melatonin is over-the-counter sleep aid, right? We are talking about medications with drowsiness. What are some of the medications with drowsiness? Very good. Hepatgil. I don't know what is hepatgil or heptagil. You need to tell me what is inside. I'm not sure of that brand name or whatever it is, right? Okay, cool. So medications, can you guys think of some prescription medications that have side effects like this? Prescription medications that have side effects like this? Very good. Antipsychotics, very good. What else? Good. Opiates, absolutely. Very good. Oh, okay, okay, okay. Anything else? So you have very good gabapentin. So you have gabapentin, right? We have tricyclic antidepressants like amitriptyline and stuff that can cause it. Then what else? You said some of the antidepressants. So tricyclic antidepressants. Anything else? Quetiapine, good. Seroquel, right? We give quetiapine as well. Then some another antidepressants like mirtazapine has a side effect too, right? These are all the medications that you guys need to know, right? These are all the medications that you guys need to know. Very, very, very helpful for the exam purposes, right? Somebody has depression and is not sleeping, you can give mirtazapine, right? So these are some of the side effects which can be useful in tailoring therapy for patients. Great, perfect. So what are the answers over here? What are the answers over here? Okay, okay, cyproheptadine. Okay, that makes sense. So the answers over here, over-the-counter sleeping medications are first line. No, they are not. So we'll say false to these guys, right? And CBT is considered a cornerstone for chronic insomnia. True or false? True. You guys might not know this, but this is true, right? This is CBT is a cornerstone for insomnia. Great. All right. Let's do some medication stuff, right? And this is a lot of this is related to the side effects and all these things. I have included some pharmacology of insomnia as well, right? So we can consider some of these things too. Any guesses? Risk of orthostatic hypotension. Risk of orthostatic hypotension. C. Trazodone. Oh, very good, Dr. Reina. Absolutely. Very good. Trazodone causes risk of orthostatic hypotension. Awesome. Zopiclone can cause metallic taste, right? Zopiclone can cause metallic taste, right? B, doxepin can be indicated for sleep maintenance, right? And then what is the last one left over here, everyone? What is the last one left? That is your temazepam. So temazepam has a shorter half-life, okay? Shorter half-life. What are some other benzodiazepines that have short half-life, everyone? What are some other benzodiazepines that have short half-life? Some other benzodiazepines, short half-life. Very good, lorazepam. Lorazepam, very good. This is very commonly given, right? Or Ativan. Lorazepam or Ativan, there's very commonly given. They have short half-life, right? Good, good, good. Awesome. Recommended follow-up time. So somebody who has acute insomnia, you have prescribed some medications and stuff like that. When do we usually follow up? 1 week, 1 month, 10 months? Approximately when do we follow up? Like recommendation for follow-ups and stuff like that? Yeah, most of you guys know this, right? About 2 to 4 weeks, right? About 2 to 4 weeks. Good, good. Okay, awesome. So let's talk a little bit about insomnia, right? I like to do questions because it just wakes you up, right? Keeps your mind sharp. And you're like, okay, let me pay attention. Let me see what has been happening, right? So let's talk a little bit about insomnia. So what is insomnia? Essentially, it is difficulty with sleep, difficulty with sleeping. Okay. What is the pathophysiology of insomnia? Well, there is a huge 10, 15 pages on pathophysiology, and you can read it by yourself about dopamine and this and that and all of that. QE1 doesn't ask specifically about the pathophysiology. Primarily, questions are case-based, right? Case-based, scenario-based questions, correct? Two types of insomnia normally we see. One is objective, where the person literally has problems, and another one is subjective, right? So you go and ask somebody, you're like, oh, okay, doctor, I can't sleep at all. You're like, oh, really? Why? Like, oh, how much do you sleep? 8 hours. Is there like any problems, any disturbances, something like that? Not at all. Any medical issues? Nothing. These guys, they sleep well, they just feel that they haven't slept well. There is a subjective component to insomnia as well, right? And you have to explore what might be the reasons behind it and everything when the patient comes to your office, or even in the exam, you have to think about, is there like underlying depression going on, maybe PTSD, abuse, what has been happening? So you need to look into a little bit towards other components which are not objective insomnia. Okay. We'll talk a little bit about differential diagnosis today, some investigations and treatment as well. Good? Okay, so let's talk about differential diagnosis. Give me some differential diagnosis of insomnia. Why does somebody get insomnia? Any guesses? Poor sleep hygiene. Very good. Bad sleep hygiene. Major depressive disorder. So we have mental health condition, which includes major depressive disorder. Maybe mania and stuff like that. Bipolar people don't sleep as well. Good. Very good. Circadian rhythm disorder, right? Circadian rhythm disorder. Very good. Good. Circadian rhythm disorder. Anything else? Dr. Amar, we wrote depression over here. Good. Circadian rhythm disorder. Anything else you guys can think of? Illnesses. Very good, Dr. Nix. Very good. So we have medical conditions too, right? We have medical. Very good. So you have issues like dementia, medical conditions, right? Or you have restless leg syndrome, right? Restless leg syndrome. Or very good, you have stimulant drinks, right? Stimulant drinks, which is exercise before sleep is part over here. We'll include it in the sleep hygiene, right? It's not like super separate, so we'll include it there. Anything else? Okay, so job that includes night duties is your typical circadian rhythm issues, right? Circadian rhythm issues. Good. Very good, Dr. Caro. Substance use disorder. Absolutely. So people using stimulants and stuff like that, right? Stimulants and stuff like that. Absolutely. Substance use disorder, right? What else? I'll include it here. Substance use disorder. If someone is in pain, they won't sleep. Sure. Anything else? Can you think of any other issues, conditions with insomnia? Very good, Dr. Nabila, you got it. This is talk of the town, and that is obstructive sleep apnea, right? Obstructive sleep apnea, talk of the town. Obstructive sleep apnea. Well, yes, absolutely. Your phone, right? Instagram. Let me see what is Dr. Muhammad doing over there. Okay. Oh, you went to Niagara Falls? What? Right? The phone, sure. We'll include that in the sleep hygiene and related stuff as well, right? Screen time and sleeping before bed and exercise before bed and all of that. We'll include that. Anything else? Any other medical conditions that you can think of, or some other conditions that you can think of? What about conditions like Parkinson's disease and stuff? That affects sleep, right? Parkinson's affects sleep, right? Yeah. Good, good, good. Awesome. What about like, what is that condition called where people like fall asleep when driving? They have like hallucinations when they go to fall asleep. What is that? What is that? Ah, narcolepsy. Okay. That is an exam favorite as well, right? Narcolepsy. Wow. Okay. Okay. So if somebody comes to you and say, Doctor, I can't sleep, will you say like, okay, here is some diazepam, go home and go to sleep. Will you do that? Will you do that? Will you say like, take some diazepam, go to sleep? No, you will not. You know why? Because you need to make sure that it is nothing medical or mental health before you even prescribe any of these things, right? So you need to make sure that there is nothing, any of this is going on, right? Like, are you drinking too much coffee? Do you have good sleep hygiene? All of that you need to cover. What else? How is your mood like? Are you anxious person? All of that you need to cover. Do you smoke too much? Five packs. I smoke one pack of cigarette from 9 p.m. to 10 p.m. Oh, okay. That's going to affect your sleep, right? Nicotine causes that. So that's another one, right? Circadian rhythm. I work night shifts, doctor. Well, that will cause issues, right? Dementia. That causes reversal of sleep-wake cycle, right? What else? Restless leg syndrome. Do you move your legs a lot? Yes, I feel like moving my legs a lot. So anytime you have restless leg syndrome, you need to make sure there's no anemia and stuff going on, right? Stimulant drinks we talked about. Obstructive sleep apnea. Do you snore a lot? Right? Patient presents with snoring, gasping for air in the middle of the night, waking up, unrefreshed sleep in the morning. Wow. Obstructive sleep apnea. Parkinson's. Do you have any tremor, rigidity, akinesia anywhere, postural instability? Parkinson's disease. Narcolepsy, right? Do you think about one day when you will become a doctor in Canada, you will be licensed, super rich person like that? It's like, yes. Well, those are hallucinations. So you have narcolepsy. No, no, right? Just joking. But if they are having hallucinations when falling asleep, or right, hypnagogic, hypnopompic hallucinations, they sitting and they just suddenly fall asleep, sleep paralysis, right? That's all narcolepsy, right? And you have other chronic medical conditions, right? You have the chronic medical conditions like congestive heart failure, wakes up in the middle of the night, paroxysmal nocturnal dyspnea, right? Diabetes, wakes up 5 times at night to go pee, right? What else? Prostate issues, wakes up 10 times at night to go pee because of prostate, nocturia, and stuff like that, right? All of these affect All of these affect. What else? There are some other medications that can affect too. What are some of the stimulant medications that people take? Stimulant medications that people take, everybody, which is talk of the town, comes to the doctor's office so often in Canada. What are the stimulant? They're the medications for ADHD, right? ADHD. Oh, doctor, I take my Ritalin sustained release at 1 p.m. It's like, okay, then you are not going to sleep until 1 a.m. because the medication is going to keep acting until 1 a.m., right? ADHD medications. So all of this you have to keep in mind when you read a question or approach a question, right? And how do you learn this? You learn it just by repetition and practice. So anytime you have something related to insomnia and you read the questions, you're like, okay, not this, not this, not this, not this. They have not given this, they have not given this. Okay, cool. This looks like narcolepsy. This is what I'm going to do. Or this like obstructive sleep apnea. This is what I'm going to do. Does that make sense, everyone? Yes, no, yes, no? Yes, no? Everybody? Yes. Okay, good, 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 good. Nice. Perfect. Very good. So these are some of the differential diagnosis. Okay. Then coming to investigations. So we already talked about a lot of investigations here, right? Like you have urine drug screen and stuff that you can do for drugs. You can give PHQ-9, GAD-7, all of that for depression, anxiety, right? Questionnaires. You can help for mental health conditions, ruling out red flags, suicidal ideation and stuff, right? Obstructive sleep apnea and other conditions. You can go for sleep study, polysomnography, right? Sleep study is something that normal patients tell you. As doctors, you can say polysomnogram, polysomnography that gives you all the things, apnea, hypopnea indexes, and stuff like that. You can look at it and see what's happening, right? So those are some of the investigations. There are not a lot of investigations involved. Essentially, you do their CBC, you do check their kidneys, you do the sleep study, right? And then depending on what the history is, then you can check for thyroid or diabetes if there is anything like that. Good. That's your investigation, right? And then we come to management, right? And then we come to management. So we have a case. 72-year-old patient comes to your office because says, Doctor, I have been having sleep issues for the longest time I know, right? Can you help me give me a sleep medication or something? Okay. How do we manage this case? Right? Patient is in our office. How do we manage this case? Right? So, how do we manage the case? We go with non-pharmacological interventions first. Remember, everybody, both QE1 exam and NAC-OSCE exam and any other exam, I would say, but both QE1, NAC-OSCE, TDM, all these exams, they focus on two components of management. One is your non-pharmacological and another one is pharmacological. For example, COPD, make sure you stop smoking. Make sure you get all your vaccinations, pneumococcal and RSV and flu shot and stuff like that, right? So non-pharmacological, we focus first, and pharmacological, we focus as well. So two components of management you have to realize, right? Sometimes in medical school we didn't care too much about non-pharmacological. You're like, yeah, whatever. Next step, give me a prescription pad. Somebody is like, all right, you have a sleep problem, done. Psht, right? So we do systematic approach, right? So non-pharmacological interventions include your sleep hygiene, right? And we talked about it. You guys know this. Don't exercise immediately before sleeping. Don't eat a large meal immediately before sleeping. Use a bed for sleeping and intimate moments only, right? There's a whole list of non-pharmacological stuff. That's number one we will do. Good. Non-pharmacological. Good so far, everyone? Yes, we are on the line. Everyone understands? Awesome. Awesome. Good. Then CBT, counseling, identifying the triggers, identifying the stressors, behavior modification. All of that is very important, right? So CBT, super important. All right, CBT, super important. Regular monitoring and follow-up. They made these changes. Did it help? Great. They added CBT. Did it help? Great. Right? What else? Before prescribing, make sure that we check what is happening, right? It's an elderly gentleman, 72-year-old. So we have to make sure that you're like, oh, what would be the best medication for the elderly patient? It's like, so what I am going to give you for your sleep is I am going to give you diazepam. Okay? Like, yes, doctor. And I have back pain as well. Okay, so for your back pain, I'm going to give you long-acting morphine. Okay, perfect. And doctor, I have neuropathy because of diabetes too. Okay, so I'm going to give you gabapentin 3 times a day. Okay, perfect. And doctor, I'm depressed as well. Okay, I'm going to give you amitriptyline for your depression. Okay, like, oh wow, awesome. This is great, doctor. You're amazing. Like I go in the bed and I never wake up because all I do is I just keep sleeping, right? So important thing in elderly is to make sure that you check, you avoid these medications because of grogginess, falls, all of this. If an elderly falls down, breaks their hip, up to 25% don't come out of the hospital, you know, because it is very hard. They lose the muscle mass, all those things. So we have to prevent them from going in the hospital, right? So before even giving medications, we need to think what is appropriate, what is not appropriate. And that's where I talked about the pharmacology of insomnia, right? Why? Because you start then mix and match. This person says, I'm depressed and I'm not sleeping. It's like, okay, I can try mirtazapine maybe. That will help you. So I don't have to get two medications for you. I have an antidepressant plus the side effect is sleepiness. So you can maybe try mirtazapine for your depression, right? And insomnia. That will help you. Great, right? It's like, well, I have some anxiety. Okay. I have sleep problems. Okay. And I have pain, like neuropathic pain and stuff. Okay. Maybe you can try gabapentin because it helps to an extent with anxiety. It helps with neuropathic pain, right? And it can make you drowsy too. So maybe try gabapentin. That will help you with that as well, right? It's like, oh, I have migraines and stuff. I get severe headaches and I'm insomnia and things like that, right? Oh, maybe consider amitriptyline or something, right? Prophylactic treatment for migraine. You can consider it. Okay. So all of these are ways of mixing and matching different things so that you can give the best to the patient. Okay. Good, everyone? Understood? Yes, no, yes, no? All right. Let's pause here.